Hello everybody, it's good to see you again. We took March off. It's nice to be back with you here in April for the 44th of our series here of these town hall conversations. You know, they wrote me a really bad pun, which is we must have hit a nerve today with our topics in neurology today, both neuropathy and multiple sclerosis. Because we had over 80 questions, which I think is a record, come in before. We obviously can't get to 80, so we've already been answering some of them one-on-one, and we'll get to as many as we possibly can today. And I'll also tell you about some ways that you can ask and get answers to some further questions. We're fortunate today to be joined by two really amazing people. First, Dr. June Lee, who is chair of the Stanley H. Appel Department of Neurology. We brought Dr. Lee in, I guess about 2 years ago now, as our chair. And one of the very first things I said to him was, hey, we need more expertise in multiple sclerosis. And so we actually have Dr. Abdul Rahman Al-Chaki with us, who's the director of our MS clinic, who joined us this last fall as one of those early things Dr. Lee did. And so we'll be really interested to hear both of their expertise today. As always, if you have questions, you can text the word DeBakey to 37607. We also have the live stream going, and so I encourage you to take advantage of that. Dr. Bing Lau, one of our neuromuscular specialists, will be there to answer any of your questions around neuropathy. We also have Amber Eggert, who is a MS certified registered nurse, who'll be there to answer many questions you may have about multiple sclerosis. And so without further ado, I'm going to turn to Dr. Al-Chaki, who's going to inform us a little bit some of the latest advances in treating multiple sclerosis. Thanks for being here.
Thank you. I'm delighted to be here to talk about multiple sclerosis and latest advances in treatment. So there are about 3 million people with MS around the world. The map down there represents the prevalence of multiple sclerosis. The dark red is where the area that has high prevalence of MS. In United States alone, a third of people with multiple sclerosis live there. So in US, there are 1 million people with multiple sclerosis. Each year, about 25,000 people with MS newly diagnosed. Most people with MS are women that count for about 75%. They diagnose mostly between age of 20 to 40-year-old. MS is rare in kids, but there are about 4,000 documented cases of people with MS under age of 18. There are 15,000 neurologists in the United States, but 400 MS neurologists. So it's a huge demand. So what is MS? Now, in the photo in the middle, this is normal brain from an autopsy. Each brain contains more than 80 billion neurons or nerve cells. In the figure to your left, this is a nerve cell that has the body and then the long axon. The long axon is covered with the myelin that protect the nerve and give it an insulation and make the electrical signal go faster from the nerve to other nerve to the muscle or the skin. Luckily, we can see a brain using an MRI without need for an autopsy. Now, in people with MS, there is a damage to the myelin. So that insulation layer is damaged, and there is a scar formed in that area. In the photo in the middle, this is an autopsy from a person with MS. And as you see here, there are like a round red area which represent the scar. These scars also can be seen on the MRI, that's represented by the white spot there. And here is the comparison between normal brain and brain with MS. Now, what causes MS? There are many factors that increase the risk of multiple sclerosis. Epstein-Barr virus increased the risk of MS by 32-fold. Epstein-Barr virus causes an infection called mononucleosis, which presents as a fever and enlarged lymph node. In people who had exposure to the virus, the risk of MS increased. Other factors include low vitamin D or lack of exposure to ultraviolet. That may explain why in the cold area, when the winter is long, there are more cases of people with multiple sclerosis. The sun helps us build the vitamin D. And then there are genetic factors. There are more than 200 genes that have been linked with multiple sclerosis. Very common question I get at the clinic, that if my parent has MS, what is my chance? And it's about 1.5% for a person who have one parent with MS. It's higher if both parents has MS. It goes between 10 to 20%. If you have a sibling, it's about 2.7%. Now, would that make MS totally genetic? It's not, because when they study it in identical twin, which share 100% of their DNA, if one of them get MS, the chance that the other will get MS is about 25%. So there are environmental factors included as well. Other risks include obesity, especially during childhood. Smoking increases the risk of MS and also increases the risk of progression for people who already have the disease. And then there's also a rule for the microbiome. Now, if these factors happen to a person who had some of them, that may alter their immune system. So the lymphocyte, which is part of our blood, they have malfunction of MS. So instead of protecting us from viral and bacterial infection, they start targeting our own body. In particular, is the myelin in the brain. They cause an inflammation that would lead the scar. People with MS have multiple scars, and this is the name multiple sclerosis. There are two phenotypes of MS. The most common one called relapsing remitting MS, when the symptoms get worse for a short period of time and then improve. And then there is a rare form called primary progressive MS, when the symptoms slowly get worse over time. For my today's talk, I will be more focusing on the relapsing remitting MS, which is the most common one. Now, this graph represents the natural progress of MS without a treatment. MS can be divided into three stages: the silent stage, the relapsing remitting stage, and then the third stage is the progressive stage. The y-axis represents the symptoms and the disability, and the x-axis represents time in years. So in the silent stage, which typically go between 3 to 6 years, it's called silent, preclinical, or prodromal. People may not have symptoms, or they may have non-specific symptoms like fatigue, mood changes, anxiety, depression, or difficulty sleeping. But if they have the MRI done for other reason, let's say after a car accident, we may be able to see the MS lesion in the brain. After that, people go into the relapsing remitting stage, and here when they start having more specific MS symptoms. These symptoms could be weakness, could be numbness, difficulty walking. They also may have bowel or bladder symptoms. Typically, they occur in relapses. Each relapse would last about 24 hours and then get better over a few days to weeks. If MS remain untreated, it may go to the third stage, which is called progressive, and here the symptoms slowly get worse over time. This is the stage when people with MS may use a cane or a walker to help with ambulation. So how we diagnose MS? We're utilizing what's called McDonald criteria. It has been updated multiple times. The last update was in 2017, and that enabled us to diagnose MS earlier and more accurately. It requires taking a detailed history, extensive neurological examination, and finding from an MRI of the brain and the spine, and sometimes other tests that may include a spinal tap. Very common question is, when I see patient in the clinic for the first time, they may have the symptoms for many years, and it can cause frustration, why I couldn't get the diagnosis early on. And there are multiple factors for that. One is the first stage is silent, or the symptoms are very nonspecific. It could be mood changes that may not, require the patient to see a neurologist. And then even when they go into relapsing remitting MS, and they have an episode, let's say, of weakness, and then improve within a few days, some patients may not feel the need to get evaluated. And then MS symptoms are diverse between patients. So there's no identical to MS patient. And there is always difficulty getting access to healthcare. Luckily, MS is treatable. This graph here shows the FDA-approved medication for multiple sclerosis. Today, there are 24 MS medications. But what I would like to get your attention on this graph, that the vast majority of MS medication were approved after 2010. So before 2010, we only had 7 medications, but we're commonly using 5. And the efficacy of these medications were between 25 to 30 to 50% to prevent relapses. After 2010 till today, the number went up to 24 MS medication. We're expecting to get 2 more this year. And the efficacy went up from 25 to 90 to 99%. What MS medication does, they stop the relapses and the progression. So in this graph, if patient with MS diagnosed with this red arrow, then our goal to change the projection from this to this. And that can be done with the current MS medication, especially when MS diagnosed early on. This graph here shows the chance of disability based on the time of the diagnosis. And as we see, people who diagnosed after 2011, they have less likely for disability, less chances for disability. And this is why we use now the term MS then and MS now, or the old MS and the new MS. So before 2010, when people think about MS, they think of somebody with disability, somebody who's using a wheelchair. Typically take them many years to get the diagnosis with a few medication options. And the age expectancy was 10 years less than average. After 2010, most people with MS get their diagnosis early. There are 24 MS medication available. Most people with MS remain without disability or with minimal disability. And the life expectancy now is average. Now, MS is complex disease. There's almost no 2 MS medication with the same symptoms. Their brain MRI, almost a fingerprint. And this is why the treatment for MS need to be tailored for each patient. And here is the rule for the comprehensive and MS clinic. So comprehensive MS clinic can help the patient achieve their goal. Does not only give the patient access to the MS specialist team, but also to other specialists, including ophthalmology, pain medicine, sleep medicine, cognitive, and neurology, besides having a nutrition program and an exercise program to help the patient achieve their goal. This is my last slide. The message that I would like to convey today, the one take-home message is MS is a treatable disease, especially when it's diagnosed early on. Thank you. Thank you, Dr.
Thank you, Dr. Al-Chaki. That's fascinating and uplifting to see that type of progress. So we'll come back and ask some questions. I'm going to turn over to Dr. Lee, who's going to talk to us about peripheral neuropathy and other neuropathies. As soon as we get his slides up in 1 second here. Tell you what, while we're waiting, I'm going to ask you a couple of questions if we can. So we've got a whole host. I'm just going to ask you a couple while we're pulling that up, and then we'll move over to him. But one question I have is there anything people can do to prevent? I'm always thinking like a primary care physician, especially young women, since it's 3/4 women. Is there anything they can do to prevent multiple sclerosis? Have we figured anything else like that, or we just pretty much don't know? And is there any role in early genetic testing to understand if you might have some predilection for this, given some of the familial ties there that you were discussing?
Absolutely. So there are risk factors that can be modified, including obesity in children, smoking, low vitamin D, lack of exposure to the sun. There are studies that show kids of patients with multiple sclerosis, if their vitamin D level is normal, the risk of having MS is the same as the general population. Now, one of the risk factors...
So somebody who has kids who has MS, they really should be thinking about talking with their pediatricians and others about things they might do, particularly around vitamin D.
Absolutely, yes, and obesity as well. The main risk factor for MS right now is Epstein-Barr virus. And there are ongoing studies to develop a vaccine. So there is a theory that if we can prevent EBV, we may be able to prevent multiple sclerosis in the future.
Okay, great. Well, I'm gonna probably come back and dig on that a little bit more. We've got the slides working now, so Dr. Lee, I'm gonna turn things over to you. So.
Thank you, Dr. Boone, for this opportunity to share my thoughts with you. And since I am the chair of the Department of Neurology, I would like to take this opportunity to do a brief introduction about the Department of Neurology here at the Houston Methodist. Currently, we have 66 neurologists across our system. We have 7 neuropsychologists and 9 research faculty who is mainly focused on the research in the neurology. So there's total 82 physicians and faculty altogether. And on the right-hand side, you see the list of different divisions of this department, which include the stroke division, neurobehavior, also called dementia division, the epilepsy division, and movement disorder, and neuromuscular disease division, which including peripheral nerve disease, muscle disease, and motor neuron disease. And then finally, there's a neuropsychology division. We, as you just heard, we established a new division, which is neuroimmunology MS division. We're in the process of establishing general neurology division as well. So over the past 2 years, and Department of Neurology had tripled our the research fund from NIH and other federal funding agency. And this is quite a remarkable progress that we have made, and really made this department highly academic. We're proud to see and also very grateful for this department being recognized, ranked number 11 by U.S. News World Report, and so that also another measure to tell that what progress we have made in the past few years. So now I'm going to turn to the peripheral nerve and system. And in order to understand the peripheral nerve, and I would like to introduce a little bit about the peripheral nerve anatomy. As you can see in this diagram, you see this pink part, which is brain and then spinal cord. And all this together, it would named as a central nervous system. And then this central nervous system will send the nerves to the arm and legs, and collectively we call them peripheral nerve system. Whenever you have any pathological condition, that nerve, we give a name called peripheral neuropathy. And collectively, that peripheral neuropathy has a very high prevalence, and depending on what study you read, and for all age groups, and the prevalence will be between 1 to 3% of any population. But if you look at the patient above age 50, and that prevalence goes really high, between 2 and 20%, depends on which study you will read. And this prevalence is comparable to the stroke, which is very high. And in terms of the symptoms of peripheral neuropathies, and we could divide the symptom into 3 groups. The first one will be mainly for the sensory symptoms. The second one is what we call motor symptoms. and the third one is autonomic nerve system symptoms. So for sensory, obviously you feel the alteration of the of your sensation, including super sensitive to the pain, to the touch. The medical term called allodynia means that normal touch on your hands and feet it's okay for the normal people, but if patients who have neuropathy, they may get super sensitive to touch. And you feel the burning pain, numbness, loss of sensation, and pins and needles, and the medical term called tingling. Also, you got trouble for balance, and because your peripheral nerve damage, you lack in the feedback system to your brain, so therefore you tend to fall and unsteady during the walking. Motor nerve damage will cause muscle weakness, muscle cramps, and sometimes twitches a lot on your muscle, and then you could lose the reflex on your tendons. And for the autonomic nerve, if that affected, you may have excessive sweating, feel hot for no reason, no unclear reason, or there's dysfunction of erection, and stomach dysfunction, and also the what we call also static hypertension means when you stand up you feel dizzy because the blood pressure drop. So these symptoms can be distributed in different kind of patterns. In some patients, they may distribute in the symmetric on both sides of the legs and hands. We call this stocking glove distribution, which is a typical pattern of what we call polyneuropathy, which means that peripheral nerve get damaged symmetrically on both sides. And sometimes that this symptom can be very asymmetric. If the symptom damage is only happen in the structure what we call plexus, and then it will only see one side of the limb, and as shown in this diagram. And sometimes that the disease affect only individual nerves, such as peroneal nerve, median nerve, ulnar nerve. So then we call mononeuropathy. And like I just said a moment ago, if the damage is the autonomic nerve, and we call autonomic neuropathy. And the recognize those kind of pattern is helpful for establish the diagnosis. So how we establish diagnosis and tradition, and the most important thing is to get in the history from the patient. Despite the advance of technology and science, that this still remain the most important thing we're doing in our clinic. We also perform the neurological examination, and then many patients will require a diagnosis tool called electromyogram. This is an important tool to measure the nerve function. And the EMG electromyogram is very sensitive to the pathology of large size of nerves, but not to the small ones. So in order to measure that small ones, we need a different tool called skin biopsy. And we obviously need to do some blood tests if we, for example, if there is certain the nutrition deficiency that causes neuropathy, we would need a blood test to figure that out. And many patients, there is a genetic mutation that causes neuropathy. We would have to do the genetic test. Rarely, we also do the nerve biopsy on the patients. Then we can look at the nerve biopsy on the microscope to figure out the cause and pathology for our patient. So with all these workup, and we are able to, based on previous studies, we are able to figure out the causes for peripheral nerve neuropathies in about 70% of our patients, and which are listed all these in here. And I won't go through each of individual of those categories, and it will be too many to go through. But I also want to mention, despite all this extensive work, we only can figure out 70%. The remaining 30% we call idiopathic polyneuropathy. So basically, idiopathic is like means that the doctor don't know what the heck of reason causes neuropathy, and that's what idiopathic means. Now there is advance in this field, and current belief of this idiopathic polyneuropathy usually represent a genetic background and their interaction with environmental factors, which just like what Dr. Archaki just said about MS. Obviously, that treatment will relate to what cause for the neuropathy. And by saying all these different kind of causes, now you realize that there's many different kind of neuropathies. So I often say that when we say peripheral neuropathy, it's a big term. It's almost like you say you have a car. You could have Toyota, you could have Mercedes-Benz. It depends on which type of those. And then treatment also different. So our diagnostic process, also your clinical visit, and we have a following important objectives. And when I see the patient, to me, that probably one of the most important things we want to achieve is to differentiate if you have treatable condition versus non-treatable condition. And because the treatable condition frequently, the earlier we diagnose this disease and give the treatment, and we will produce the better outcome. And obviously it's very important. If it is not treatable, then we're going to have to tailor our management toward the alleviate the symptoms, improve the quality of life, and in those kind of disease, that's the main goal we try to do. So the treatment, I will mention several examples about the peripheral nerve treatment. And the first one I want to mention is the peroneal nerve palsy, which is one of the individual nerve in the leg, and sometimes gets injured and then causes the foot drop, and then the patient have trouble to walk, loss of sensation in the leg. Now these sometimes can be caused by the spontaneous onset of these nerve problems, but they could be caused by injury, or even their tumor grew in the nuchal area that caused the peripheral nerve damage in that specific nerve. So therefore, we have to figure out the specific cause for that individual nerve, and then take into action and take action to fix the cause, and usually needs a pretty good outcome. And many people have a false perception that if it is inherited condition, there's no treatment. That's also not true anymore. For instance, there is the disease called hereditary sensory autonomic neuropathy type 1C. It's a rare disease, but the scientists figure out that this disease caused by a mutation in one of the enzymes that catalyze a biochemical pathway. That pathway now can be manipulated through the vitamin supplements to reverse the pathology, which is very important to recognize because it's treatable. There are inflammatory nerve problems such as the chronic inflammatory demyelinating polyneuropathy, which is responsive to the treatment, and therefore it is important to recognize early, and because the earlier you treat, and the better outcome is going to be, because when the disease dragging too long, it causes more nerve damage and then become hard to reverse. And there's also a category of disease that called perineoplastic neuropathies, because they're hidden cancer. Before the cancer even manifests out, they produce antibody, attack on the peripheral nerve, and cause neuropathies. And obviously, this is very important to recognize because that will trigger a search of the underlying cancer, and the earlier we find the cancer outcome will be far better. So we're at Houston Methodist, we now have a Charcot-Marie-Tooth disease and recognized by CMT Association as CMT Center of Excellence. And this is a multidisciplinary care model that Dr. Archaki also just described about his MS clinic, and it will be participation with peripheral nerve specialist, physical therapy, occupational therapy, EMG technician, genetic counselor, and also the orthopedic surgeon. And we operate this clinic as a one-stop shop, and so that way that for the convenience of our patient. And obviously, we also are very interested about the quality of care, because through this multidiscipline, and we give the patient the best of care. We are part of this inherited neuropathy consortium, so we have a collective effort to advance the research of this disease through this network. We have established a research program through this platform and aiming to develop the therapy for our patients. So we want to expand this model further to the entire peripheral nerve spectrum and through this multidiscipline care. We're in the process of build this up and recruiting the director for the peripheral nerve center. As you all know, that there's 18% nationwide shortage of neurologists, and the access is become a big issue and nationwide. And through this multidiscipline approach, we hope that all improve the access as well. So I'll stop here and thank you for listening.
Thank you very much, Dr. Lee. Appreciate that very much. Also fascinating. Again, we have a lot of questions to cover, so I'm going to try and keep things moving. So I just want to drill down a little where we were. You were talking about Epstein-Barr virus, possibility of vaccine preventing most MS. It sounds like, I mean, as I understand, you said 32 times the risk if you've had EBV, but of course, most of the population, or much of the population, gets EBV. It's mono, right?
Sure.
As a young person. How many cases happen in people who've never had EBV? Do we see multiple sclerosis in that group? And then why just, I mean, it's 32x, but it's not, you know, a done deal that you will get it if you have that.
That's a very good question. You know, one of the slide, I present a study. I didn't talk much about it, but a few years ago, they did a study that they look at the U.S. Defense database for all the people who have MS. And in that database, there are blood samples, you know, before the diagnosis. And so they found 801 patients with MS, and all but one have an EBV positive before the diagnosis. It also was seen that they get the EBV, and then they get a marker called the neurofilament light elevation. So that's an evidence that there is a brain damage even before they get the symptoms. In the clinic, almost always, patients with MS have positive EBV. But you're right, you know, EBV is very common, so we don't want to scare the public. Not everybody with EBV or mono will get multiple sclerosis. Actually, most people who get EBV will not get multiple sclerosis. Right. But it seems EBV is one of the main reasons, kind of like a rare complication, let's put it this way. One of the rare complications of EBV is to get multiple sclerosis.
And I mean, it's implicated in a number of other diseases, not again as a direct cause, but a big risk factor. So we could really change the trajectory if we could prevent it by vaccinating.
Absolutely.
Okay, well that's really helpful. And then one other question of mine, and then I'm gonna get to some others. The genetic side's fascinating. So 25% of twins have it. So there's other things happening along the way. Or another way to think about it would be, could there be some of those twins who actually have it, we just haven't figured out they have it? Is there any possibility of that? I mean, are tests sensitive enough? We can sort that out, and it's been well studied to understand that?
Sure. So, you know, identical twin, there's a difference between, you know, identical twin and non-identical twin on the prevalence of multiple sclerosis. So it is higher with identical twin if one of them has multiple sclerosis. There are different studies. The risk were between 20% to the 30%, so there's never 100%. And that also guides us that there's probably more like an environmental factor. It's more like a domino. So you maybe have a gene, but you need something to activate it, like an EBV, for example. Also, you know, identical twin, most often they live together, they grow up together, so they have exposure to the same environmental factors as well. The gene that most associated with multiple sclerosis is called HLA-DR-B15, and it's regulate the immune system. Having that gene increased the risk of MS by threefold. So it's not even higher than the exposure to the EBV virus. So there is a genetic rule, but it's still MS. It's not a genetic disease. It's probably a combination of factors.
Thank you. Well, that's very, very interesting. So, you know, we got a couple of questions here. I'm going to around pregnancy and breastfeeding. Obviously, you know, this is, as you said, most commonly 20 to 40 women, 3 to 1, 3 to 1 women to men. So obviously that's childbearing age. So you deal frequently with a pregnant MS patient, I'm sure, or a breastfeeding MS patient. Could you talk about how you manage that, the risks there maybe are of exacerbation, and then really what you have to do around treatment, if anything, to change it?
So this is part of the personalized plan for people with MS. So family planning is important. The 24 MS medication available, some of them are safe during pregnancy, some of them are not. Most people with MS during pregnancy, their MS relapse rate goes slightly down and then increase after the pregnancy. So some of MS patients may be able to stop the MS medication safely during pregnancy and restart it after. People who are at high risk, we can choose a medication that it's steady and safe during pregnancy. And the same thing with the breastfeeding. I would say the vast majority of MS medication are compatible with the breastfeeding. There are few that they are not. So trying, you know, if person with MS planning for pregnancy, it is important to share that with their neurologist, just so they have, you know, choose the medication that would fit them the best.
Okay, so it can be managed just deliberately, I guess, during that time, for sure. Is there any risk to the fetus? Is there any more high risk of the actual pregnancy itself?
So most people with MS, they don't consider high risk pregnancy. There is no a complication for the kids just because their mother has multiple sclerosis. Now, there's some MS medication that increase the risk of fetal abnormality, so that's need to be avoided.
Great. Well, thank you. Well, I'm going to turn things to Dr. Lee. I often start with prevention questions. Again, my primary care hat. You know, the best way, if you could, to not suffer from neuropathy is not to get it. So what can we do to prevent neuropathy? And I know that's a very loaded question because of that huge list you showed us of causes of neuropathy, but are there things as people get older they can do to minimize their risk of suffering from neuropathy?
Sure. I think that if you look at all these causes, the most common cause for the peripheral nerve diseases is what we call metabolic syndrome, which including the abnormal for your sugar level, that's a diabetes, and then there's lipid problems and etc., and obesity, and all these what we call the metabolic syndrome, and that induce about 1 to 3% of among all the population above age 50. So it's an extraordinarily common condition we're talking about. Just the diabetes alone, 12 million people in the United States, people have diabetes, but about 8 million of those were affected by the diabetes to cause peripheral nerve diseases. So if we live in a healthy lifestyle and reduce obesity, have a metabolic syndrome controlled early, and we would prevent lots of people to have a peripheral nerve disease. Just that one item alone, it's going to be very significant.
Okay, so surprise, surprise, watch your weight, eat well, don't have diabetes, et cetera, et cetera. I mean, it comes up everything we talk about here,
yes.
For sure. You draw a distinction, I think, between metabolic syndrome and diabetes. Those are obviously, they're overlapping circles, but is it diabetes more common than metabolic syndrome, all of the above?
I think in terms of cause of peripheral nerve diseases, I think the diabetes is the most common one, and probably right below that it will be the metabolic syndrome, which many people has that.
So we had a question come in about, okay, because obviously it's very common. You mentioned treatable causes, reversible in some cases. where's diabetes on that spectrum? Somebody who suffers, because obviously, as you said, it's, I don't know, almost 2/3 of the diabetics, as you're talking about those numbers, are having some degree of neuropathy. It's part of a screening exam for every diabetic who sees their ongoing caregivers. What can be done about that?
So obviously you will need to control the glucose level well. But study has showed that if you make your glucose level in the perfect level, you still get peripheral nerve diseases. So obviously there's additional factor contributed to the diabetes. For instance, there are a number of studies has published there's polygenic effect of the diabetic neuropathy.
Many genes. You're
there's
saying.
Many genes that there's a whole bunch of genes that in the background of individual human being that would contribute to likelihood of developing the peripheral nerve damage in the diabetes among the patient with diabetes. And so therefore that perfect control does not guarantee you will control the diabetic neuropathy. However, the good news is that there was a study done that the people who have diabetes, and they randomized the two different groups. So one of them is under the close watch of physical therapist and to follow the exercise protocol and diet control protocol, and the other group did not. And then they follow up by skin biopsy, so they can look at pathologically and look at the nerve density in the skin that represent the capability of regeneration. What they find after the 2 years of that, and the group who exercise diabetic control and actually show that there is increased the regeneration of the peripheral nerve, which is quite remarkable. That tells you that this really made a difference for those patients.
Okay, that's an interesting thread I want to pull there. Regeneration.
Yeah.
A lot of people think of the nervous system as, you have a nerve injury and you're sort of out of luck. Your nerve is injured. In this case, you've got obviously disease of the nerves that's happening. Can the body regenerate? Can we figure out how to get it to regenerate better?
Yeah, so the peripheral nerve naturally has the capability of regenerate, and the common term that people use and to tell the people is about 1 inch every 3 months, and so there is regeneration capacity. Obviously, that also that there's a lot of important factor is that between the end of the damaged nerve toward the target that you try to innovate. For example, if a motor nerve and damage that have 1 foot long from the muscle, and that will take a long time to regenerate. Even by the time you get to the target, the muscle probably already gone. So the precision control, the guiding the nerve to the target, and also the timing, how fast these can get to the target, is another important factor to consider. So even you have a capability to regenerate does not guarantee that it's going to have effective, functionally meaningful regeneration. So that's lots of science behind all this, and that's lots of research also under this, and try to figure out how we help the peripheral nerve regenerate faster and precise to regain the function.
Great. So I want to ask you a broad-based question. You chair the department, right? So you see the whole field of neurology. You both do, but you in particular, because you have all these pieces reporting up to you. I think about MS, and this is a field within neurology which has progressed amazingly. We just saw that, right? The kind of pre-2010, the after 2010 statistics. What area of neurology is ripe for that next level of transformation? What do you see being that next place where we start to accelerate progress as quickly as happened in MS?
Yeah, I think there's lots of exciting area that in the neurology right now. And if you look at when I was a resident, and during that time, if you look at the neurology field, hardly very much therapy available. And for the stroke, aspirin, that's about it. But now you have whole lanyard of the therapy. MS, the same thing. So there's numerous progress has been made over the past couple of decades. I will say that the things that will make huge difference right now in the field of the neurology is one is that we now have a whole set of the capability to manipulate our immune system, which Dr. Achaki has described. We also now have tools that we never had before for gene therapy and capability of editing gene, capability use the antisense oligo, bring into the system manipulate gene expression that really revolutionary and already made a success examples in the spinal muscular atrophy and a few other monogenic diseases. And the other thing is that the advance is the informatic tool that we never had before, that the computerized system be able to manage the huge amount of the database, then allow us to make a right decision and also being able to personalize our therapy to individual person. And those are the probably most important thing, which is quite exciting.
It's a very exciting time in neuroscience. I think we're seeing the field just flourish and the impact on people, which is what matters most. So exciting. Well, I'm going to ask you a couple of pretty specific questions, Dr. Ochocki, that have come in. I want to make sure we get to these. This is very relevant here, especially at the time of year we're entering. How does heat affect MS symptoms, and are there cooling strategies or other things to put in place for somebody with MS?
Sure. The way I explain it to my patient is our computer is like, our brain is like computer. So if the computer gets overheated, it shut down, and that's the same thing with the brain. So multiple sclerosis and heat and humidity doesn't go well together. People with MS very often, when they had exposure to overheat, their old MS symptoms come back, get worse temporarily. Once they cool down, the MS symptoms will improve. One of the way to help with that, especially if you live in Houston during the summer, is to use a cooling jacket. So these are, a jacket that has like bucket for, you can put an ice on it, and make sure that you keep yourself hydrated. Use an umbrella, be on a shadow area.
Okay, fantastic. Also got a question about fatigue, how do you manage the fatigue related to MS? I know that's a common symptom. Is that impact, when you look at the pathway there and kind of halting progression, are you halting the progression of all these exacerbations, or some of that underlying fatigue, does that get improved as well?
Sure. So fatigue is a very common symptom of MS. I would say the vast majority of people with multiple sclerosis have fatigue to different degree. When I talk about fatigue, it's kind of like the energy of the brain. So it's like our phone, when you go tonight, you put it on the charger, you wake up and you have the 100% battery, that's the same thing. People with MS, when they go to sleep and if they have a good sleep, they wake up and they have a lot of energy, but they consume this energy way faster. So by noon, they have no energy to do anything else. So one, want to make sure that they recharge very well. That means they have a very good sleep. That's why we make sure that our patient get sleep study evaluation, and there's any problem with that, try to fix it. Second, we also utilize energy during the day. So if there's things that can be done by other, it's probably better to be done by other, not by them, because they will consume less energy to do the exact same thing. There are multiple medication available to improve the energy in multiple sclerosis. And probably the one best factor to improve energy in MS is an exercise. Now, 20 years ago, we tend to tell patients don't exercise because when they do, they feel tired. But now there are many research that show that people who exercise regularly, they have more energy build up over time.
Fantastic. Well, that's very, very helpful advice. Thank you. I want to thank both of you for being here. Fascinating topics today. Obviously, something that people found very interesting with all the questions that were sent in. I hope you've been using the chat function, because a lot of very specific questions sometimes are best answered that way as well. So I'm going to give you a quick update on Houston Methodist. These are some slides I've shared with the board recently, just a few goings on at Houston Methodist, and then we'll wrap things up after that. I was talking about focus on the fundamentals, the awards will follow. Well, every time somebody measures where are the best hospitals, very gratifying to see that we're always making those lists, it seems like. Newsweek's in this business now, so when they put us on the world's best hospital list, Fortune, working with a research company called PINC, does a top 100 hospital list, and you can see every year we do really, really well. So they kind of carve it up into sizes. So they have 15 in the large academic size, and and Houston Methodist Hospital and the Medical Center was number 5 in the country there. They do kind of large community-based teaching hospitals. I think there's 20 of those. Sugar Land and Baytown were on those large community hospitals. We had the Woodlands and West, so really great performance. And this is focusing on the fundamentals, and those awards tend to follow. And speaking of fundamentals, one of ours is being very, very innovative in driving our Center for Innovation. This is now a couple years now. Fortune's been putting us, I think we were number 11 this year. We were number 10 last year of most innovative companies when we look at these lists. And also Forbes, second time in a row now, top 10 large employers, not hospital systems, large employers in the country as a best employer. And that really warms our heart, because when we have great people working here, we have great outcomes, and our culture is the center of everything we do. Just a couple other highlights and bragging on a few of the great people here at Houston Methodist. Dr. Pedro Ramirez, who is our chair of obstetrics and gynecology. He's an expert in gynecologic oncology, actually was invited to give an editorial in the New England Journal of Medicine. It's always a really big deal to get published in the New England Journal if you're doing a study. It's also a really, really big deal to do an editorial, because they're looking around to say, hey, we have this important study. There's 1 or 2 editorials a session, and we need an expert to put that in context of all the other studies. So this is a real feather in the cap of Dr. Ramirez and by extension, Houston Methodist. The guy over to my left here, Dr. June Lee, congratulations, Dr. Lee, who was just elected Secretary and Treasurer of the Association of University Professors of Neurology. So we're very proud of him, representing us very well on the national stage. One of our orthopedists, Dr. Tim Brown, just got named to a list of the top 1% of academic orthopedic surgeons. So another individual we're very proud of late. And then this past month has been Donate Life Month, and so a big celebration of that. You see this amazing photo done in the ground floor of the outpatient center. I was unfortunately out of town, so I didn't get to photobomb this with them. But you can see Paula Walter right dead there in the center. Of course, this is the J.C. Walter Jr. Transplant Center. And look at the amazing cadre of professionals there supporting individuals who benefit from solid organ transplantation at Houston Methodist. And remember, if you're not an organ donor, sign up, become an organ donor, because you really can obviously change the whole course of a person and a family's history in the future. And then I'll wrap up just acknowledging 2 of our physicians, and really all of our physicians. We celebrated Doctors' Day at the end of March, as we always do, and at HMH had just wonderful performances and wonderful awards. Kind of the pinnacle award is the Overstreet Award. You see on the left, Dr. Robert Jackson receiving that, and on the right, Dr. Neil Kleiman, 2 long-term experts, or doctors at Houston Methodist. So we're proud of each of them. We're proud of all of our physicians who so fabulously take care of our patients around Houston Methodist. So with that, I'm going to wrap up. I'm going to thank everybody for being with us today. I want to thank Drs. Lee and Alchaki for their presentations. Just fascinating and really inspiring to see the progress that's being made, and really I think the heyday of neuroscience and really moving knowledge forward. I want to thank Dr. Bing Lau and Amber Eggert, who were on the chat answering your questions on the live stream. I'm sure you've kept them busy. We will be back actually on Tuesday, June 4th, another Tuesday instead of what you're probably used to with Thursdays. We're going to do the Bookout Center for Medical Innovation, Technology, Research, and Education, really focusing on developing robotics and imaging and other things in the future, and look forward to seeing you then, and happy spring to everybody.